Good afternoon and welcome to HIT Policy Update COVID-19 Special Edition, a Health System CIO Media Inc. production sponsored by Saykara. Just a little housekeeping before we get started. My name is Anthony Guerra and I'm the Editor-in-Chief of Health System CIO, and I will be your moderator today. We have some interactive features we're going to be looking at today. You've got your questions and comments. You can send them in to us as they occur to you through the Q&A box. You can download the deck by using the URL on your screen, and it's going to be sent out in the chat box. And we've also got a special COVID-19 resources list that Dr. John Halamka is going to tell you more about, and you've got the URL to go ahead and get a hold of that resource list. So you see how we are going to spend our time today. First, we're going to go approximately 30 minutes. We're going to hear the featured presentation from Dr. John Halamka, president of the Mayo Clinic Platform. Then we're going to have a brief interview with Dr. Graham Hughes, president and COO with Saykara, our sponsor today. And then we're going to have our audience Q&A, and we're going to make sure we get to as many of your questions as we possibly can. So without further delay, I'm going to turn it over to our good friend, Dr. John Halamka. Dr. Halamka, thanks for making time today. I know you are a busy man these days.
Well, thanks so much, Anthony. And I guess I would want to start by saying, folks, what an amazing time we're all living through as we are connecting to this webinar through our home offices as we are practicing social distancing. Graham is a physician, I am a physician. I think we should start by saying, folks, watch your sleep patterns. Watch if you're sleeping a lot more, sleeping a lot less. Look at your caffeine consumption, a lot more, a lot less. Your alcohol consumption, a lot more, a lot less. I mention these things because these are all hallmarks of anxiety and depression. And as we are going to probably be socially isolated for the next 16 weeks, that is likely to be more and more common. So just recognize all of us are feeling these feelings. All of us are struggling, but by keeping ourselves together in webinars like this, Anthony, where we communicate, share ideas, and collaborate, we'll get through this. So let's start on some of the policy changes. It has been a remarkable 3 weeks as we look at the movement of medicine from bricks and mortar to a more digital delivery environment. And today we'll talk about telemedicine, remote patient monitoring, virtual hospital, but we'll also reflect on the ONC and CMS final rules. So why don't we go ahead to the next slide. And so one of the things that, of course, we have to think about is what is the role of HIPAA? So, Graham, I'm sure as a practicing physician, you've heard, oh, you can't text a patient. That's a HIPAA violation. Well, the reality is, of course, you can text a patient as long as the patient agrees that using a free text unencrypted message is okay with them. Well, that's interesting. So we've always had the ability to use novel communication methods if we got patient consent and there was complete education and understanding. But in a world of COVID, where we're moving all of our visits virtually, and we're using a variety of platforms, some of which may have BAAs, some of which don't. Some devices might be encrypted and some may not. There are risks, of course, of doing this. And so what we have is guidance from the Office of Civil Rights that says that during this crisis, we are going to have a waiver of HIPAA penalties and sanctions. So this idea is if we are doing all our best to deliver remote care, and along the way, we happen to be using a platform or device that isn't traditionally, covered by the HIPAA privacy and security rule protections, there won't be penalties or sanctions should there be a problem. So you can see some of the specific waivers that have been identified, the requirements to obtain a patient agreement to speak with family members or friends. How many of you are now trying to be the care traffic controllers for your household? Right? It's going to require a team of families working together, so there has to be really a waiver of that. Or opting out of a facility directory that, we need to coordinate medical record exchange. We need to be able to figure out where you've been. We might even, over the course of the next couple of weeks, have contact tracking apps so that you can be notified if when you were in a facility, there was somebody also in the facility who potentially could have infected you. So it's important that that's waived. The requirement to distribute notice of privacy practices in a telehealth world where you are providing care in novel delivery mechanisms, but also novel providers you might not have met before coming together to help you, may be hard to distribute privacy practices. Patients' right to request privacy restrictions and segmentation of their record is going to be waived for the interim. And then confidential communications, specifically saying, no, I won't use an unencrypted channel. No, you can't text me. So I tell you all this, obviously all of us are patient-centric and privacy is a great focus, but these are simply sanctions that will be waived as we all understand we need flexibility and deliver care in a digital fashion and do so in such a rapid way that none of us could have even planned for. Along the way, obviously, we're all going to do everything to keep the patient data secure and private, but it certainly is beneficial that OCR gives us flexibility during the transition. So let's go to the next slide. So let's talk about telemedicine. And so what we recognize is telemedicine and telehealth means a whole lot of things, right? I do 900 telehealth visits personally each year as the nation's expert in poisonous mushrooms and plants. And I tell you that because how did I have to do that? Imagine I'm licensed in Massachusetts and Minnesota. A patient in North Dakota has a poisoning. Do they contact me directly? Oh, they can't because I'm not licensed to practice medicine in North Dakota. So what they do is they contact a physician in North Dakota with a license who then contacts me, and I provide that physician with advice, and my treatment plan is delivered by the licensed physician in that state with their discretion. That's how it had to work in the past because medical licensure was at a state level. Although things like DEA and opioid prescribing rights, may very well be a federal number, that the individual licensure and practice scope was set by states. So what we have now seen is there are waivers that get around the state requirement to have local licensure in the delivery of telehealth care. So I show you this slide for two reasons. One, what we have are a series of CPT and HCPCS codes so that various types of telehealth visits and remote care, whether that's a new visit, a repeat visit, a check-in visit, or remote patient monitoring, all of these things are now billable. There are ways to process all these transactions, and there is the waiver of the state-level medical licensure. So in effect, licensed clinicians who are appropriately credentialed and qualified can deliver care in 50 states and charge for that care. So obviously, this has been percolating for years and not making a lot of progress. And the fact that we've now been able in a matter of days to implement these relaxations of the telehealth delivery restrictions is extraordinary. And Anthony, what I tell you is the changes that we make during this COVID era are likely to stick post-COVID era. So I think it's important that all of us, work through these logistics, figure out how we're going to do record keeping and continuity of care and revenue cycle. Now, this all being said, the one thing that I have to be a little careful of is it's so early in the game, I haven't seen actual revenue cycle reports that show what reimbursement levels for these HCPCS and CPT codes actually are in practice, or what are the private insurance companies per state doing. And let me mention this. So in the state of Massachusetts, Governor Baker has ordered all private insurers to reimburse telehealth visits. So in Massachusetts, even the private insurance companies are affected by these kinds of thoughts. But I imagine in each state, your experience will vary. And the concern you have as we move to so much digital and virtual care delivery, if reimbursement levels are lower than a traditional office visit, we are going to see significant financial strain on many of our healthcare institutions. So This is one to be watched. Obviously, many organizations, private sector and public sector, working to encourage telehealth. It's good for the patient. It's good for the healthcare delivery system because we don't bring infected patients into the proximity of caregivers, because if caregivers themselves get sick and have to be quarantined, that adds another level of complexity. So that's telehealth, but let's talk about other kinds of remote care delivery. So let's go to the next slide. And this gets into, a little bit of policy weeds, but here's the issue. I think we agree that an ambulatory visit can be done through a standard telehealth application. Many companies have been doing that for a while. What do you do if a hospital is utterly overwhelmed and cannot deliver care to all the COVID patients, the ventilators that are needed, the intensive care needed? Well, certainly one thought is decant hospitals in this country of all non-COVID patients. Congestive heart failure, COPD, UTI. I mean, these are conditions that can be treated in a not traditional setting. And that's fine. So when we think about the tech, we're going to do telemetry. So that's pulse, blood pressure, urine output, glucometers, maybe such things as pulse ox, sleep patterns, all kinds of telemetry. It's going to be supply chain coordination to the home. It's going to be getting the right services, home nursing, EMTs, paramedics. It's going to be bringing in specialists and virtual visits. All of these things are doable from a technology standpoint, but these are the regulatory issues. Imagine that a hospital is going to get $20,000 for an inpatient congestive heart failure patient DRG. And then they say, oh my God, we need to decant the hospital to free up the room for COVID patients. We're going to send them to a home hospital setting where there's no DRG and there cannot be laboratory testing, radiology testing, third-party services provided. Suddenly, the revenue cycle collapses. And I can tell you what the numbers look like. People are at the moment going to lose about $7,000 per patient they transfer out of a bricks and mortar facility into a virtual hospital or home facility. So what do we need to do to make decanting patients in this country possible? One, we need a DRG that enables an acute care hospital to transfer a patient to another setting of care without reducing the reimbursement. And so DRG recognition coming. There's this 2 midnight rule idea of, what qualifies an inpatient stay. Oh, it's you've had 2 midnights in a bricks and mortar facility. Well, again, we would rather them not even come to the bricks and mortar facility. So the 2 midnight rule is certainly not something that you want in place. Where can nurses practice? What if we take a nurse from a bricks and mortar setting and move that nurse into a home setting? Is that allowable? What are the licensure issues or the scope of practice issues? What if we wanted to provide ancillary services like lab and rad in the home, or take a patient from the home to a local radiology center, get the test done, return them to the home? Whole variety of stark anti-kickback issues, and we need to make sure we relax those. And what is the cost to the patient of these services? And so I tell you all these things because everything that you see in front of you on this slide has been presented to the White House, has been presented to HHS and CMS. And my hope, and Anthony, I want to be really careful not to overpromise anything to the people on this webinar, is that by the end of this week, we will have a DRG for virtual hospital care, whether that's delivering care in a home or the Jacob Javits Convention Center, right? That is, there may be these large hotels, convention centers that are put together to deliver alternative kinds of care. And these issues that I've described on this slide, it conceivably by the end of this week may have some resolution. I mean, we've seen HHS offer sub-regulatory guidance on telemedicine very quickly. A lot of smart people in CMS are considering these issues now, and hopefully we'll get adjudication soon. So those are some of your COVID-related policies. I do want to highlight, Anthony, that you do have a spreadsheet that is being made available as part of this webinar that was prepared by McDermott, Will, and Emery, Karen Sealander. And it has the up-to-the-minute regulatory changes related to COVID. It includes legislation, regulation, and sub-regulatory guidance all in one spreadsheet. And so, it certainly has a number of the things that I've described today about HIPAA and telemedicine. And that is something that I would encourage all of you to take a look at. It is extraordinarily comprehensive and should answer any of your questions. It was updated this morning. Well, let's move on now to the ONC and CMS final rules, because I know we wanted to talk about those. And so, we know that we have the final rules in place that were issued. They're supposed to be the first day of HIMSS, but they were, because HIMSS was canceled, released on that Monday, the first day of HIMSS, by CMS and ONC as final rules, with a set of implementation timeframes in 2020 and 2021. Let's review for a moment what those rules say, and I only included these slides because in my conversations with leaders at ONC and CMS, although there is seeming pressure to rethink the deadlines for these rules, at the moment, I have not seen any specific action taken to extend those deadlines. So it does mean that these very well may apply to us in the deadlines that have been stated. And why would that be? Well, you can see some of the reasons for the rules to begin with are so that patients can more easily access their medical records. They can exchange them as they wish. They can reduce their cost of care. Well, think about it, in a COVID virtual world, it's going to actually be more important than ever that you can be the steward of your own healthcare data and go to a provider you may not have met before and exchange your medical record and be able to get to that right provider for the right service at the right time at the right cost. So I think the notion is, boy, these APIs and these requirements on transparency and the ability to get that information without blocking are actually more important than ever. And that, of course, includes responsibilities for doctors' offices and hospitals to not make paper charts available or PDFs, but in fact, via FHIR APIs, ensure that any app that is appropriately functional and standards adherent at patient request with appropriate authentication and authorization can download a standard electronic form of that patient's what we call US CDI, or the core data set for interoperability. And of course, this also has implications for the EHR vendors. They all, on each of their EHR products, will have to make standard APIs with this US CDI and the so-called FHIR R4 implementation guide available. It will reduce burden on them because it makes it clear that one standard, one implementation guide, one constrained set of data has to be made available. Now, Anthony, this is interesting. There was a huge material change in this final rule that people may not have noticed. But the original rule said your whole medical record. Well, what's your whole medical record? Your toenail length? Your hair color? Right? I don't know. Right? So this rule has now been constrained to say these APIs apply to the US CDI, the core set for data interoperability, which includes problems in meds and allergies and labs and RADs and care team and care plan, but doesn't include the million other things that potentially could have been in a medical record that have no standards associated with them. I was always worried about the burden on developers, but also the burden on apps and the challenge of just trying to do this plumbing with a lot of data that has absolutely no standard or format. So using US CDI as part of the final rule was very reasonable. And obviously the whole notion here is we're going to have increased innovation. Every day I'm getting new apps to evaluate for COVID, and they are really interesting, like tracking where you've been and figuring out if others who have been infected have been in a place where you've been, all while maintaining privacy. And so these kinds of innovations are all going to be possible with this final rule and more APIs. But let's drill down a little bit on some of the final rule criteria. Go to the next slide. So remember, there were two rules, the ONC rule on information blocking and the CMS rule on interoperability. And so what you see is 21st Century Cures, which inspired these two rules, has now made ONC look at different ways in which they will certify products. First, there has to be there's an information blocking rule. We'll go through the details of what information blocking is, but basically your product cannot block the flow of information for care coordination or the delivery of patient records to the patients. There has to be a standard application program interface. There has to be some usability. There has to have been appropriate testing to make sure that the burden of being able to exchange medical records securely with these apps isn't so hard or expensive. And there are restrictions on the amount of fees that can be charged for this interoperability, provider to provider and patients. Well, next slide. So all that's handled as part of certification of the product and, of course, attestation of its use. So let's just talk about what these APIs are. So remember that an API is just a mechanism by which data is in a standard format, queryable through a query response type of transaction. I say, I want Anthony's record, here are the security constraints around that, and then I get back in a standard way the problems, the meds, the allergies, and the like. And as I said previously, this is all the United States core data for interoperability or US CDI standard, and that the ONC will ensure that certification has the implementation guidance so that we are clear that every EHR product will have a standard API that is certified that can be consumed by any app or any service that has appropriate authentication and authorization that comes knocking. So this is an exciting move forward for interoperability. The EHR vendors have already created much of this technology. Some of the challenge will be workflow, admittedly, figuring out what apps are able to access this, or what if, and Anthony, I pose this as a hypothetical. What if two guys in a garage in Shenzhen create an app, and that app happens to take your data and without your knowledge share it on Facebook? What do we do about that? Right. And so there's going to be, certification, there's going to be review, but as we actually implement this stuff in actual workflows, we'll probably have to have some levels of curation and approval. And I think the good news is you're going to see in the next slide, information blocking does in the final rule give us a set of exceptions that would enable us to say, actually, we're not going to send data to that app developed by the two guys in the garage in Shenzhen. So in fact, let's go to the next slide. Okay, and so when we look at some of the information blocking and exclusions, remember, so information blocking is this idea where it is a volitional, this is not because of incompetence, or this is not because of, lack of technical capacity. It's a volitional where a party in the ecosystem is interfering to discourage access, exchange, or use of electronic information. And so I think that this notion of information blocking sometimes has been more political and psychological than technical, right? I don't like your organization, therefore I am not going to allow you to access data. So this notion of sort of volitional behavior to prevent the exchange of information is now prohibited, and there are fines. But there are exceptions, and let's drill down on those exceptions because they're actually pretty reasonable, and you really need to have exceptions if you're going to roll this out. So let's go to that next slide. And so let's just give it some examples of a kind of exception. So, well, what if, and Anthony, I'm going to make this up completely, but what if I am going to share data about you that causes you harm? And, this is going to be a little bit a difficult thing to assess, but maybe it's going to be, I have an app that gives you your problem list. You just had a biopsy. Your problem list now has cancer listed at the top. And via your app, you're going to discover your cancer diagnosis. Well, how should we do that? Is there something that takes into account a provider-patient relationship and does this in a bit more, appropriate fashion? And so, where or if I were to share data in a way that would cause a patient harm because of some privacy concern, how do I ensure we protect the patient and respect the patient's preferences for privacy? Or if it causes this material security risk, like the app I mentioned from the two guys in the garage in Shenzhen. Or if it's just technically impossible, right? I mean, let's just make up something here. Imagine this requires a robust internet connection and you're in a critical access hospital that doesn't have an internet connection. Right. Or there are various sorts of things that HHS and ONC have suggested are just very reasonable that I imagine that will be used with discretion by provider organizations as they try to comply with this, such that they're given some flexibility of implementing it. Well, let us go to the next slide.
I think that's your last one.
Yeah, and so, okay, I didn't know if I had the question slide. And so let me just summarize by saying, so what I have seen over the last 3 weeks is amazing private sector stepping up to the plate, companies working together to create novel solutions of everything from IT to supply chain to data analytics. And there is a national coalition that MITRE is currently serving as program manager for. And that has now included about 100 different companies coming together just to help each other with no specific economic interest. So huge amounts of collaboration, good regulatory waivers on the telemedicine side and the HIPAA side, hopefully soon getting waivers on the virtual hospital, more acute care side. And we'll see what happens with the timing on the ONC and CMS final rules, but they do have exceptions. And certainly I think some of the stuff contained therein is going to help COVID anyway. So with that, Anthony, let's turn it back to you. I know you're going to have a discussion with Graham, and happy to take any questions.
Good. I anticipate questions. Yes, we're going to have about a 5-minute chat with Graham, and then we will take questions. So go ahead and send them in, and we're going to have plenty of time for them. So Graham, thank you for sponsoring, and thanks for spending some time with us today. You want to start off by telling me a little bit about your organization and your role?
Yeah, absolutely. Hi, Anthony. Hi, everybody. And John, thanks again, as usual. Very clear, very nicely communicated state of the state. So Anthony, Saykara is a Seattle-based AI scribe company. So we're focused on reducing physician burnout. And our AI, Kara, runs on an iPhone and it interprets the natural conversation between the physician and patient in the exam room. And it assembles a high quality, billable, structured note, as well as helping to pen orders, referrals, and follow-ups for physician review and sign-off. So basically the idea is get untethered from the computer, get away from the tyranny of the keyboard, focus on the patient. And so we eliminate all after-hours charting day one as soon as you start using this thing, and it'll save up to 70% of your overall documentation time. And that, like I say, frees up time for doctors and caregivers to spend time doing what they got into medicine for, which is to see patients and think about what they need to do rather than just documenting their care. And if they want to, what they want to do with that time is up to them. Many of them will see more patients. Some of them just spend the time with their families. So I'm the president and COO. I'm a physician from the UK by background, but a bit like John, I've spent the last 30 years or so in health information technology in a variety of different roles.
Very good. Thank you, Graham. You guys are based in Seattle, definitely one of the earliest and hardest hit by COVID-19. What are you hearing out there from your customers, prospects? What are people going through in the trenches? Anything you want to share for the benefit of our audience today?
Yeah, no, you're right. We were, I think, sort of the earliest hit, and maybe not now so much the hardest hit, but we've had over 2,500 cases in Washington State and about 135 deaths, unfortunately, and a lot of that is in the downtown metropolitan Seattle and Bellevue area, and so we've probably been experiencing this maybe longer than anyone else. We've been social distancing, working from home, and we've all non-emergency or non-essential businesses now been shut down. Everybody's working from home. I'm here with 4 other family members working from home. So, we've seen this unfold real close and personal. The situation continues to evolve, obviously, here, just like everywhere else, on a daily basis. But the one thing in common from our customers is that this is all consuming at the moment. It's the planning, readiness, and execution are all continuing all the time. So it's not like you plan once and then you just, you then work on that. Everyone is continuing to evolve as this thing evolves. And that's from postponement of elective surgeries, drive-through testing, virtual visits, as John said, looking at alternative facilities, dedicated triage centers, retrofitting of hospitals, clinic settings. And the big concern, Anthony, remains capacity, ICU beds, clinical staff, PPE. We even had hospitals locally that were getting folks to help jump in and sew face masks. We've had a bunch of folks in the local community manufacturing now jump in locally to just help out to develop PPE. And whether it's the effect of social distancing, or the closure of non-essential businesses, and these stay-at-home mandates, we'll see if they're having sufficient enough effect to flatten the curve. I think that the expectation is in the next 2 weeks or so, they're anticipating that we'll get the peak of our hospital and ICU utilization. So certainly by mid-April, we'll know whether this is working.
Very good. Now, you mentioned physician burnout. That's a topic that we cover regularly in our webinars, a huge issue. It's amazing to think that if a lot of physicians were on the verge of burnout before this, we can only imagine the effect that this is having. Although, I mean, I don't know, perhaps, in some ways it's invigorating to have such a focus and such a challenge as opposed to the mundane. But talk about that, the burnout, whether or not you think this is going to push things further, and then, a little bit about, how your product aims to alleviate that burnout.
Yeah, no, absolutely. Well, it's interesting. John touched on a number of this, but we've got doctors locally in some of the largest systems, whether it's Providence, St. Joseph, Swedish, Multicare, many doctors using care on a daily basis. And they were using it obviously before the crisis, and they're relying potentially even more heavily on this as we get into the crisis, particularly in primary care, but in some of these dedicated triage clinics. And so more organizations are coming on board in the region as we speak, but also nationally. And we've repeatedly heard that reducing documentation time and effort associated with that during this crisis is a priority in all settings of care. So it's because it frees up caregiver time to spend on the patients. And, oftentimes they'll be gowned up. They'll be, having to try and reduce, the risk of contamination. And so voice is a natural way of interacting with an electronic record and to interact with your patients. So to that end, last week we announced that, small as we are, we're making Cara free for COVID visits. And so we're working in as friendly a manner as we can, but that's both for in-person and virtual visits. And so we're starting to roll out what we call a COVID pathway, which is, the AI understands what it's listening for URI, upper respiratory tract visits. And not just in Seattle, but wherever it's needed. And we'll do that for as long as we can, just to do our bit. It's something we're just seeing nationally that, this is helping to allow docs to focus during the time of COVID.
All right, Graham. Well, thank you very much. That's about the time we had for our little interview. So I want to appreciate, again, your sponsorship and making this event possible. I really do appreciate it. Now we're going to go back to Dr. Halamka. and we're going to jump in with our questions. So, plenty of questions here. This is always the most fun part, right, Dr. Halamka? All
Indeed.
right, first question. Yes, first question. Any discussion about delaying appropriate use criteria / CDSM mandatory start date, which is currently scheduled to be mandatory in 2021?
And I asked about that yesterday, and as I was highlighting in my comments, that I have not heard any delays. I mean, obviously still being discussed. A lot of folks are suggesting that it creates undue burden to have the start dates in the same time frame as proposed. But this is the question: what's the benefit to the patient? And might, in fact, these things be actually materially important for COVID response and its aftermath? So wish I could give you a concrete answer, but as of yesterday, I've heard no delay.
Okay, we'll take it. All right, next question. Any progress on standards for SDOH as part of the med record?
So I think they're meaning social determinants of health.
Yeah, yeah.
Right. So it's interesting. Obviously there are groups that continue to work on social determinants of health standards, but at least in my conversations with Chuck Jaffe over the last couple of days, much of the work on standards over the last few weeks has been creating what I'm going to call the minimal COVID data set for exchange. So sort of interesting issues there is, sure, the minimal COVID data set for exchange is going to, by definition, include some social determinants of health. Right, because you're going to need to understand, is somebody homeless? That's got implications, or access to care or other things like that. So I would just tell folks, yes, it's being worked, but in the short term, it'll probably be social determinants of health as applies to COVID as we come up with a minimal COVID standard. All
right, next question. Much debate on how to meet ADT requirements and the 6-month deadline. Are HIEs a possible solution?
It's interesting that one of the things that seemed to change in the final rule is discrimination between what is an institution, what is a network, what is an HIE, has kind of all been removed. And so I think really the answer there is that rather than specifically focusing on one entity to deliver this functionality, the assumption is there are modular components out there, some provided by the EHR vendors, some provided by organizations like Care Equality or Sequoia, and some provided by Commonwealth, and that you assemble these as would be necessary to achieve the result you need. I have not seen a specific focus on returning to an HIE model to meet these particular needs.
Okay, very good. Next question. Lots of concerns expressed about third-party software and lack of security. Recognize that we have heard from federal agencies that it is between the patient and the software vendors. Your thoughts, please.
Okay.
So little clarification there. The last question is related to the security of the API and data sharing.
Yeah, no, I got that. Yeah, and so we had a lot of controversy about that. And, there were certain figures in the industry that seemed to offer controversial opinions. I actually sat down with a number of figures in the industry and I said, well, what are your real concerns? And in fact, their concern was not about information blocking, intellectual property, or competitiveness. It was about this exact issue, which is, so Anthony, have you read your Facebook end user license agreement? Oh, I'm sure you have. It's 4-point type. It's 9 pages long. What was on page 8? You remember? Right? And so to say we are going to now require every patient to read and digest every end user license agreement does seem a bit unrealistic. So what you wonder is, Anthony, you're old enough to remember what a good housekeeping seal is.
Yes, I am.
What you wonder is, coming out of all this, might there be a service that is offered by a nonprofit or a private company, who knows, where they say, actually, we have read the end user license agreement, and this app does protect your data. It doesn't sell it to third parties. It doesn't push it to places you don't want it pushed. Because I agree with the question I get it. We want more data liquidity. We want more patient control and data stewardship. But at the same time, we can't expect every single patient to read every single end user license agreement. I hope we would offer them some relief.
All right, very good. Next question. Will the DRGs account for the fact that overhead is less in a home than in a hospital? Isn't the shift to the hospital in the home supposed to help flatten the cost curve?
And of course,
from the hospital to the home.
Yeah, no, it's too early to know. I get it, right? That is, in theory, when you've looked at the work that's been done by Medically Home, Contessa, and others, that there is the belief that you could potentially reduce your hospitalization costs 25%. And so, maybe the answer, again, we'll see hopefully in the next couple of days, the DRG might create a number which is still viable, right? It doesn't go from 20,000 to zero, but it will go 20,000 to 13,000 or something, so that it recognizes the cost of delivery is less, but it still is significant because you're going to need all that telemetry. You're going to need the virtual visits. You're going to need the home care staffing. You're going to need the paramedics and EMTs on supply chain. So there's still substantial costs. So a fair point, should be somewhat less, but certainly can't be a whole lot less.
All right, very good. Next question. Does the final rule prevent others from monetizing my PHI without my consent?
Well, okay. So here's where this gets a little bit complicated, right? The idea of this API is that it is going from the covered entity to you. And once it is deposited on your device, it is under your control. Now, what if you volitionally go to an app store, download an app that monetizes the data that is on your device, and you give it full permission to access all that data because you didn't understand the end user license agreement, right? So that's the risk, right? So there is no notion of some company getting access to your data without you. The worry would be you giving access without understanding how the data is going to be monetized.
All right, very good. Graham, I want to bring you back in here. Wondering if you have a question for Dr. Halamka.
Yeah, John, reading between the lines here, do you see certainly the idea of sort of pulling in the request for FHIR APIs. One of the things obviously that we try and do is we're interested in not only pulling data to help the context of a note, but also to push data back. And
right.
The things that isn't very granular at the moment is that ability to push data back into an EHR in a way that maybe is a pending state. Is there anything that you see in the ruling that unblocks the need for EHRs to accept inbound data at a granular level?
Yeah, so he asks a complicated question. So, because here's one of the problems. The referential integrity of the data in an EHR requires a certain schema, requires certain error checking on parameters and values, right? So the challenge with a write back is, in effect, you have to replicate the entire business logic of the EHR in the API that is accepting the data for write back. So where am I seeing this actually being done, right? Obviously, we've got such things as HL7 V2 ORU, right, where you can send a result in. Or OBR, you've got I can send a dictation response in because there's a dictation interface. So yeah, at the moment, a lot of this data input is V2. I have also seen proprietary APIs for which the EHR vendors have made APIs available for novel workflow. Like, for example, Graham, maybe you wanted to send a message into the inbox of the provider. Well, there is an EHR-based API that allows you to write to the inbox of the provider. It's just not FHIR-based. So there is no requirement in the rule for write back. Everyone's working on the notion of write back. We all think it's important. It's a lot of technical challenge that we still have to work through.
Dr. H, any final thoughts?
Well, I would just say, as you look at your inbox over the course of the next few days, you will be asked to help. And, you know, again, my wife is sewing masks. I'm being pulled into ventilator procurement and blood sample collection, convalescent plasma clinical trials. You'll never know what your inbox will contain on a daily basis. And so this is an opportunity for leadership. You know, this particular next 16 weeks will try us. As I said, our anxiety and depression will go up, but you can really make a difference. So look at that inbox. Even if it's out of your comfort zone, pitch in, because without working together, we can overcome this.
All right, let me go to Graham, and I just want to mention to people that there is a section of the slide deck today that has a sort of an overview presentation about Saykara. So I just want to mention that that's in there. So Graham, your final thoughts.
Yeah, I actually, one of the things that we're seeing it here, right, which is that virtual meetings, virtual visits, and virtual encounters work real well, and we're all getting used to them. And I think that that's one of the things that we're seeing that's here to stay. And it's also why we're at the moment about to release a plugin into Zoom, because you know, there is a HIPAA compliant version of Zoom, and we think that it's going to far outlast COVID. Is that the effects of virtual visits and virtual visits being part of life is where we're going to all be. So we anticipate plugging into that, and then plugging into more and more and more of those virtual visit technologies, because that's just the way that business will be and care will be delivered.
Well, excellent. That's about all we had time for today. Again, incredible stuff from Dr. Halamka and Dr. Hughes. Thank you so much for joining us. Regarding continuing education, you can use this final slide in this deck for your CEU needs. You'll get an email as soon as the on-demand recording of this event is up. If you want to sponsor one of our upcoming events or book your own custom event, you can reach out to Nancy Wilcox from our team, and you can go to our website to register for our upcoming webinars. So with that, I want to again thank Dr. John Halamka, Dr. Graham Hughes, Saykara for sponsoring. And I want to thank everybody for attending today, taking time out when I know you have a lot going on. So with that, everybody have a wonderful day. Thank you.
Thank you.